Welcome to the AMCP Science and Innovation Theater on understanding the devastating impact of complement C3 glomerulopathy and primary immune complex mediated membranoproliferative glomerulonephritis, or for short, IC-MPGN. Today's presentation is going to focus on the high unmet need and costly implications of these rare and chronic glomerular diseases. Important information to start with. This presentation is intended as communication under the FDA Drug and Device Manufacturer communications with payers, formulary committees, and similar entities, and related question and answers to the extent applicable. The information is intended to payers, formulary committees, and similar entities with knowledge and expertise in the areas of healthcare economic analysis and responsible for the selection of drugs for coverage and reimbursement. This slide deck is not intended to be substitute for consultation and review of reference materials and medical literature pertaining to individual clinical circumstances. Healthcare providers should make all treatment decisions based on the context of the situation and their clinical judgment. The speaker has been compensated by Apellis Pharmaceuticals for the presentation of this educational information. This presentation is a C3G and primary immune complex MPGN disease education program, and the efficacy and safety of investigational compounds will not be discussed. About myself, the speaker, let me just introduce myself. My name is Jean Francis. I'm the medical director of the kidney transplant program at Boston University Medical Center. I'm an associate professor of medicine at Boston University School of Medicine, and I'm the medical director of the pancreas transplant program at Brigham and Women's Hospital, and I'm also an associate physician at the Brigham and Women's Hospital. So I obtained my medical degree from the Lebanese University School of Medicine, and I completed medicine residency and nephrology fellowship at Yale University at St. Raphael campus. I subsequently did kidney and pancreas transplantation fellowship at Beth Israel Deaconess Medical Center and Harvard Medical School. I'm currently, as I mentioned, the medical director of the kidney transplant program at BU Medical Center, and I serve as the director of the combined pancreas transplant program between BUMC and Brigham and Women's Hospital. I conduct research in the kidney transplantation, and I have a special interest in thrombotic microangiopathy and complement-mediated diseases. I am also an accomplished educator, and I have won several excellence awards in teaching, and I'm also the recipient of the 2022 National Kidney Foundation Award for Excellence in Nephrology and Kidney Transplantation. Next, before we get into the presentation, I would like to open up with a video about a patient living with C3G to help provide context for the impact of living with C3 glomerulopathy.
A lot of people hate running. I look at it as like a form of like freedom or meditation. I'm a young guy. I've always lived my life. I've always had my basic like health abilities, which is like walking, talking, and breathing. And going through that kidney transplant, I remember coming out of that surgery and I did not have those things. My name's Chase. I'm 22 years old, and I was diagnosed with C3G back in 2nd grade. Lived with that disease my whole life. That disease, ruined my original kidneys, causing me to have a kidney transplant at the age of 20. My mom's been my ride or die, obviously, since I was born.
I would describe Chase as a very energetic, dynamic person. It was very hard raising Chase. He never stopped. I noticed Chase's eyes were puffy. That went on for a couple times. We were in Maryland on vacation, and his whole body swelled up. It was really to the point where when we got back from that vacation, I went right to the hospital.
And I was in the hospital, I think for like 7 or 14 days. They were taking blood work, they were trying to figure out what all happened, and that's when I was diagnosed with C3G.
You have an 8-year-old boy who's just, what do they want to do? They just want to run around and have fun. It wasn't fear, it was more frustration. The research on the C3G there wasn't that much information. Chase was stable with his kidney function for many years, and right around 1819, his kidney function started to decrease.
And then when I graduated high school, I'm out here doing my own thing, being my own boss, loving my business. I was like sitting in an office out of the blue. My doctor's like, yeah, your function's decreasing, you need a kidney transplant.
Chase was put on the National Kidney Registry for a deceased donor when he was at 20%. And within like a year later, it was at 5%. We didn't know if we were going to get a donor in time or if he was going to have to go on dialysis. His father went and got tested. So finally we got the approval for the transplant. The operation was very successful.
Coming out of the transplant, like my health completely changed. You realize you were sick. The kidney transplant is not a cure. It's really just giving you more time. It's just a lease on life.
The fears to me would be, is he going to need another transplant? Is the disease going to become active again? You kind of worry about things like that.
One of my hopes is that there's a treatment for C3G so patients will not have to get a kidney transplant. I'm just an optimistic person, so I always look at the future. I always stay positive.
I'm really thankful to the people who are doing research in this rare kidney disease. It's just very hopeful to me so that other children don't have to go through what Chase went through.
So you can see it's a lifelong disease that we have to deal with. So C3G and primary immune complex MPGN are rare chronic glomerular diseases. There are about 5,000 patients in the US with relatively even split between the diseases. These diseases are thought to be caused by overactivation of the complement system, leading to excessive deposition of C3 breakdown products in the glomeruli. There are estimated, as I said, 5,000 cases in the US of both diseases. And these diseases result in devastating kidney damage. Up to 50% of the adults, patients with C3G progress to end-stage kidney disease within 5 to 10 years. Of patients who experience disease recurrence post-transplant, allograft loss occurs in up to 60%, and many of them require many transplants during their lifetime. They require clinical and pathological evidence for diagnosis, and as of now, there is no approved targeted treatments to prevent disease progression. I should say that one drug was approved last week for the treatment of C3G, but as of now, there is no yet FDA-approved drugs for the treatment of immune complex MPGN. As you can see on the right side here, this is the MPGN appearance on light microscopy. It's a disease pattern. It does not lead to a final diagnosis of anything. Further studies are needed to kind of confirm what's the underlying process leading to the MPGN. In C3 glomerulopathy, you'll have a dominant or just pure deposits of C3. In the immune complex, you'll have deposits of C3 and immune complex deposits that are most of the time equal. And in the C3 field, when you look under electron microscopy, you can have two types of diseases, either the dense deposit disease, where you have this dense material depositing into the basement membrane, or you will have scattered deposits, dense deposits seen on electron microscopy compatible with the C3 glomerulonephritis. So different complement defects can lead to C3 glomerulopathy and primary immune complex MPGN. We know that the alternative pathway is always idling, or what we call it's a constant ticking or tick over mechanism. So it's at baseline constantly active. In C3G and primary immune complex MPGN, the complement system is persistently in overdrive, often because the brakes are not effective. And this can lead to overconsumption of C3, excess of C3A and C3B production, which leads to massive inflammation inside the kidney, scarring and injury, and C3 breakdown products deposition in the kidney. The primary causes of this disease are the presence sometime of what we call C3 or C5 nephritic factors. Those are autoantibodies that can stabilize the convertases in the complement pathway, leading to overactivity of this alternative pathway. And sometimes there's genetic variants in complement-related genes in up to 25% of the patients. I should mention that immune complex MPGN can exist in secondary form, and there are secondary causes for it, like chronic infections with hepatitis B, hepatitis C, or HIV, autoimmune diseases like lupus or Sjogren's syndrome or rheumatoid arthritis. Sometimes it is seen in association with monoclonal gammopathy, especially in patients above age 50. In kidney transplant, MPGN can be seen in the form of transplant glomerulopathy in the setting of chronic antibody-mediated rejection, and some malignancies are also associated with MPGN. On the right side, it's a visualization of the complement system, which we know can be activated via 3 pathways: the classical pathway, the lectin pathway, and this is the one that we are interested in the setting of C3G and immune complex MPGN. It's the alternative pathway. It's constantly ticking, and upon further trigger, it can go and override, especially if the brakes are affected, mutated, or are blocked by autoantibodies. And this leads to overactivity of the alternative pathway, abundant production of byproduct of the C3, which can deposit in the kidney and lead to inflammation and injury. So how does C3G and primary immune complex MPGN present? So this continued complement overactivation is thought to cause glomerular inflammation and subsequent scarring, which may lead to chronic and irreversible kidney damage, which could manifest with low serum C3 due to excessive deposition of C3 breakdown products in the glomeruli and overconsumption of this complement product, fatigue and edema, reflective of poor kidney function, hematuria due to damaged glomeruli that allow red blood cells to pass through the filters. Proteinuria also is caused by damaged glomeruli that allow protein to leak and pass through. Hypertension, which can be severe, it's a common manifestation of the MPGN, and decreased glomerular filtration rate due to severely damaged glomeruli that are no longer filtering the blood appropriately. So what about disease progression and recurrence? As I mentioned earlier, up to 50% of adult patients with C3G progress to end-stage renal disease and kidney within 5 to 10 years, and may need chronic dialysis and eventually kidney transplantation. The risk factors which are associated with a faster or rapid progression to end-stage kidney disease include age above 16, which is the age at diagnosis, low eGFR at time of diagnosis less than 60, the presence on electron microscopy of supportive evidence for dense deposit disease, and histology showing crescentic glomerulonephritis. It is important to mention that a 50% reduction in proteinuria within the first 12 months of diagnosis with supportive care that is available now in the setting of C3G is associated with a lower risk of kidney failure. So anything we do to lower the degree of proteinuria is helpful in slowing down the progression of the disease. Kidney transplantation, although it's the treatment of choice, it is not curative for patients with C3G or primary immune complex MPGN. Disease recurrence occurs in up to 89% of the patient, and when this recurrence takes place, the graft loss is happening in up to 60% of the patients. So that's why patients require 1, 2, or 3 kidney transplants during their lifetimes, and the disease will always recur. So while the clinical presentation, serology, and urinalysis can help point to C3G and primary immune complex MPGN, a definitive diagnosis requires renal biopsy. Immunofluorescence staining of the tissue is needed to distinguish between C3G and primary immune complex MPGN. Immunologic and genetic tests can help further support this diagnosis, but renal pathology expertise is needed to confirm a definitive diagnosis. So it's a collaborative work between nephrologists, pathologists, and laboratory doctors to kind of like make a determined and final diagnosis of those rare diseases. So with no FDA-approved treatments, current therapy is limited to supportive treatments. I should highlight here that one drug was approved last week for the treatment of C3G, but there is no approved drug so far for immune complex MPGN. So supportive therapy is based on administering ACE inhibitors and angiotensin receptor blockade. And this is typically used as a first-line therapy. It aims at the reduction of proteinuria and controlling the blood pressure. And there is some evidence that it substantially improved renal survival in retrospective studies in French patients. Immunosuppressive agents could also be used, and the aim is to limit the inflammatory effects of the complement overactivity in the kidney. There are conflicting data on efficacy. Some studies report an impact on renal survival, while several studies report no change in progression to end-stage kidney disease. Plasma therapy and exchange, because it can remove autoantibody and mutated proteins and supplement the newer active proteins, there is some belief it could work, but it lacks robust data that supports its efficacy. There are occasional case reports describing favorable outcomes when a mutated protein is causally implicated. Diet changes apply to every CKD and not just to C3G and immune complex MPGN, and they should be practiced. Reduction in salt intake, reduction in protein diet to reduce the waste load and the overactivity of the kidneys and the overload on the kidneys. Those are measures that support good health and are encouraged. So current therapies, as you can see, are limited to supportive therapies, and they just control symptoms, but there is no therapeutic agents that are available so far. What about the economic burden of chronic kidney disease in the United States? As you can see on the left side, as you progress in your stage of chronic kidney disease, there's an exponential growth in the cost and the burden of cost. On the right side, you can see that the cost assessment for kidney transplantation and dialysis, the estimated cost for dialysis was $292,000 per patient over 10 years. The dialysis medical expenses were estimated at $72,000 per quality adjusted life year over 10 years. Transplantation is also costly. The costs were estimated to vary by donor type from $250,000 to above $440,000 over 10 years. Kidney transplantation is the optimal therapy for end-stage kidney disease for prolonging survival. Despite higher total cost, kidney transplant was cost-effective across all donor types. Patients with C3G and primary immune complex MPGN often require frequent healthcare visits leading to substantial cost. Although data describing the economic burden of biopsy-confirmed C3G and immune complex MPGN are lacking, a claims analysis has been conducted looking at the clinical and economic outcomes among patients with idiopathic membranous nephropathy, another rare disease, glomerular disease of the kidney. More than 2,600 commercially insured patients with membranous nephropathy diagnosed between January 2012 and December 31st, 2015 were identified and met inclusion criteria. Remember, this is 10 years old study. So whatever numbers you're going to see, they have to be adjusted to the current costs. The cost outcomes were assessed for all patients as well as cohorts of the top 5% of patients contributing costs, and they label those as high-cost cohort, and the remaining 95% of patients, non-high-cost cohort. As you can see, the mean annual cost per patient was $45,000, approximately $46,000. 12.7% of patients had 1 year cost exceeding $100,000, and the top 5% of patients had a mean cost per patient of above $400,000. And when you look at the proportion of the cost, the outpatient visits occupied 47% of the cost, the inpatient care occupied 31% of the cost, and the prescription used 22% of the cost. And the patients were found to have a frequent outpatient visit. On average, patient had 9.7 outpatient office visit, and on average 24.5 other outpatients visit, including outpatient, hospital, and end-stage kidney facilities. And I can assume that what you see here on idiopathic membranous nephropathy could translate to other rare glomerular disease, such the ones we're describing today and we're discussing today. So in summary, or to sum up today's presentation, C3 glomerulopathy and primary immune complex MPGN are driven by complement pathway overactivation, and they require renal biopsy and histopathological analysis for definitive diagnosis. Without disease-modifying therapies, current treatment focus on symptom control and on just supportive care. What about the high unmet need? There are estimated 5,000 patients in the United States with relatively even split between the two diseases. Kidney transplantation is not curative, and disease recurs in as many as 89% of the patient receiving transplant. Patients with glomerular disease like C3G and primary immune complex MPGN have the potential to incur substantial costs and have frequent visits to the healthcare system. Thank you for your attention. And now I would like to use the remaining time for some questions on this webinar presentation and on C3 and primary immune complex MPGN.
Great. Thank you, Dr. Francis, for that great presentation. We will now open the floor to your questions. Remember, you may submit a question or comment by typing it in the box at the bottom of your screen. So we have a couple here already for you, Dr. Francis. The first one is, what role do patient education and multidisciplinary care play in managing C3G and primary IC-MPGN?
Yeah, that's a great question. And I'm going to just use two examples to highlight how important is the patient education. Number one, in our institution, for example, we instituted a thrombotic microangiopathy team we call the TMA team. It's a multidisciplinary team that deals with a complex disease like TMA. We also shifted the team to care for patients who have complement-mediated disorders. On the top of those is the C3G and the primary immune complex. As you saw in the movie of the patient that we shared, it's a lifelong disease, extremely complex. It's extremely difficult to diagnose. And, it requires collaboration between different specialists, essentially nephrologists, pathologists, laboratory people. So I think, having this multidisciplinary approach is essential in educating the patient and also nailing the diagnosis and making the diagnosis as accurate as possible. Patients will have to deal with this chronic process of progression over years of their life. As we showed in the slide, in 5 to 10 years, 50% of the patient will end up on end-stage kidney disease. So it's a life commitment to chronic kidney disease by the patient, and they become experts in the field of complement, in the field of chronic kidney disease, and they remain constantly in touch with their provider, and they become highly educated. And this is very important to them to be able to live normal life and understand their disease and deal with the chronicity of their disease.
Great. Are there data that demonstrate the relationship between early clinical presentation and long-term outcomes, such as kidney failure, progression to ESKD?
Yeah, early diagnosis and early intervention with the standard of care that is available now, with most of it is supportive care. And if you are able to intervene early and in the process before extensive scarring have taken place in the kidney, and if you can reduce the proteinuria, you can definitely slow down the progression of the disease and delay the progression to end-stage kidney disease requiring either dialysis or transplantation. So yes, early identification is very important, and implementing the supportive therapy that I discussed as early as possible, and hopefully its ability to reduce proteinuria will have a big effect in delaying the progression of this disease to end-stage kidney disease.
Awesome. And on a similar note here, we have a very similar question. Are there data on survival rates, kidney function preservation, or need for dialysis, transplantation with the current treatment options?
Yeah, we mentioned that in our slide that over 5 to 10 years, 50% of the patient, despite every effort you make, all the available supportive therapy, immunosuppressive therapy that is available now, 50% of them will reach end-stage kidney disease by 5 to 10%. The remainder, might reach it at a longer period, or they will live with chronic kidney disease or slowly smoldering progressive kidney disease. So there is limitation to this standard of therapy we have available now, but unfortunately, it's the only thing we could offer.
All right. And then what is the long-term efficacy of the current standard of care, and how often do patients require intervention?
The efficacy is very limited because you're definitely not addressing the underlying process of the disease, which is the overactivation of the complement. So those medications will just reduce proteinuria. Some immunosuppressants we use might ease the inflammation and delay the progression. And I don't think they are able to stop the process of the disease as we know, but you can probably delay the need for dialysis, and even after transplant, if the disease recur, the same implemented, and remember it occurs on triple immunosuppressant most of the time. So the supportive therapy was ACE and ARB. If only it can reduce proteinuria and slow down the progression of the kidney disease. It's not going to stop the process.
And then how do C3 convertase and C5 convertase differ in their role with the complement cascade for C3G and primary IC-MPGN?
Yeah, you have to bear with me with a little of immunology here to answer this question. As you know, C5 convertase is very important in the production of what we call the membrane attack complex. It's in the terminal part of the complement activation. And, we know that people with C3G or immune complex MPGN, if they have a C5 nephritic factor, which affects the C5 convertase, will have a high level of soluble MAC. It's a measurement we do to see the disease activity. And, but in my opinion, it's the proximal complement activation, which is the C3 convertase per se, plays the dominant role in the process of this disease. And it's this proximal activation leading to massive deposits of complement C3 and C3 byproducts in the kidney that is the potent driver of the disease. So I see it more as a proximal complement disease more than distal complement disease, and I see a more pronounced effect of the C3 convertase as compared to the C5 convertase. So I think it's a proximal alternative pathway disease rather than distal alternative pathway disease. So it's more C3 convertase role than C5 convertase role. I hope this answered your question.
Absolutely. And then what can formulary decision makers do now to better support patients living with these diseases?
I think they need to understand that we are struggling tremendously with those patients. And like sometimes we are prescribing those supportive therapy without strong evidence, but it's the only thing available. And I think they should keep their eyes open for any new drugs that might come that might address the underlying process. So, as of now, I think, we use some immunosuppressants. We don't have solid data to use them, but that's the only treatment available. Like we often use steroids. We often use, for example, other immunosuppressants like Cellcept or Myfortic. Those are like the mycophenolate. There's some data to support those immunosuppressive, but as I showed you in the slides, there are data that showed that they don't work. So we struggle tremendously, and I'm hoping the future is going to be brighter. And decision makers have to be keeping their eye open for what might come in the future that might address the underlying process of this disease.
All right. And how are patients with C3G and primary IC-MPGN currently being managed?
uh, difficulty because we don't have anything that can stop the process, the underlying process, pathophysiological process, if you want, of the disease, which is this overactivity of the complement. And we give, as I said, non-specific immunosuppressants to reduce the inflammation that is caused by this overactivity of the complement. Sometimes they work, sometimes they don't. And we use a lot of supportive therapies with, what we call glomerular hemodynamic modifiers like ACE inhibitors and ARBs, trying to reduce the intraglomerular pressure, reduce the filtration of protein in the kidney, in the urine, this proteinuria, which we know if you reduce it, you could reduce the mechanism of injury to the kidney and delay the progression. They work to very limited ability. They're not gonna stop the process. They might, at the most, slow the progression, but not stop it.
All right. Thank you for that. Next question. How does diagnostic delay affect long-term outcomes and healthcare resource utilization?
Yeah, unfortunately, delay in diagnosis means leaving the kidney under the attack of the complement for a longer period without intervention, although those interventions I mentioned are limited, but they can slow down the damage process. And, if you end up at the time of diagnosis with extensive scarring in your kidney and you have already lost a lot of your EGFR, you're destined to a much faster progression to requiring, a renal replacement therapy when you end up with end-stage kidney disease, such as, dialysis or kidney transplantations. And as I showed you in the cost slide, at every stage, CKD is, exponentially growing. When you advance in the degree of CKD, the costs grow exponentially, but they grow the most when you are on dialysis and or even on transplantation. So definitely they're going to be having a big burden on the medical system. They require frequent visits, they require frequent admissions, they require multiple interventions at that stage, and the cost will explode at that time.
Yes.
So early detection is very important, and trying to give the available supportive therapy is very important in the hope of trying to delay the progression and reduce the burden and the cost on, payers.
Absolutely. And you touched on this a little bit, but I do have this question here too. So if there's more you want to say on the topic, how do difficulties or delays in diagnosing these diseases affect your patients?
Yeah, unfortunately, we see a lot of patients who have been like jumping from doctor to doctor, and no official diagnosis has been done, and no appropriate therapy has been implemented. And you can see that those patients, and most of them are young, end up on dialysis at very young age, requiring a transplantation at a very young age, which means, in the setting of disease recurrence, they're going to require 1, 2, or 3 or more kidney transplants. So it's a huge burden on the patients and their families and on the medical system in general. Unfortunately, if we can avoid that, that would be fantastic.
Of course, yes. And then I got another question here. How does standard of care treatment compare to the standard of care for other types of kidney diseases?
Yeah. The standard of care for the C3G and the immune complex MPGN, I'm not sure if we can call it standard of care. It's supportive care. We don't have a standard of care yet. And, if you compare it to other diseases, let's take, for example, diabetes. We know now there are some standard of cares. You give them SGLT2 inhibitors, you give them GLP-1 agonists. So there are some data on those drugs that can slow down the progression of disease, reduce cardiovascular mortality. They are pretty effective. They are turning into standard of care for the management of those diseases. We don't have that yet in those two diseases, C3G and IC-MPGN. And I'm hoping that the future will be brighter for that, for those diseases once we have something to call standard of care. So we are still using supportive care. It's not, we call it standard of care because we don't have anything else yet. But definitely other diseases are way better than those two diseases now. Like if you take diabetes, if you take lupus, there are some standard of cares now, and we know they work and they are utilized and they are guidelines advocates for them. But we're not there yet with those two diseases we're presenting here today.
All right, well, thank you. Thank you to Dr. Francis for speaking today. And thanks to our sponsor, Apellis, for providing this webinar. And thank you to each of our attendees for joining us today. Be sure to look at our list of upcoming webinars at amcp.org/calendar. This concludes today's program. Thank you.